Hello, everyone, and welcome to this week's COVID Insights to Action. I'm Fred Goldstein with VeiligHealth and Accountable Health, and I'm here joined today by our two physicians. This week, we'll be discussing vaccinations, facts and myth. It's an interesting topic. Obviously, there's been a lot out there, and we'll dive into it with our physicians. As we go through this today, if you have any questions, as pointed out in the chat box, please feel free to put those either in the chat box or the Q&A. We'll be monitoring those. If you'd like to get involved and actually come on screen, you're welcome to do that as well. Just ask us, and feel free to ask questions however you'd like. So why don't we start today's session with you, Dr. Nick. Tell us a little bit about some of these more out there types of myths that we've seen or heard over the past coming months regarding the vaccines.
So we were talking about this before we started, and I was trying to think about the myth that bothered me the most. And the one that really struck me was the 5G myth. It was related not so much to vaccines, but to COVID-19 in general, and that 5G towers were causing COVID-19 disease. And I think it bothered me the most because it was actually associated with damage. People were going and burning these towers. These are cell phone towers, and there was a major reaction. So first off, when I talk about myths, I always ask the question of people, what information would change your mind about this particular opinion? Unfortunately, a lot of the time I receive an answer that is nothing. I've confirmed my view, so it can be a little bit challenging, but let's break that one down a little bit. 5G is just another part of the spectrum. We have no instance of radiation that's coming from these towers causing any viral disease. We know that there's an association, and we can see the link between the virus and the disease. We can demonstrate that somebody that has it has the virus who never comes in contact with 5G, because they're nowhere near any of these towers, would actually get the disease. So if it was related to the towers, we would see these clusters of people. So there's a number of scientific facts that would essentially dissipate that, but that didn't stop it from being permeated and promoted out on the internet. But, let's just knock that one off to one side and say there is just no evidence to support that at all.
Right. It makes a lot of sense, particularly as you think about just 5G out there in general. There are many parts of my community I'm in right now that don't have any 5G towers and no service here in the United States, let alone around the world. And you begin to say, well, then how did the virus get there?
Right. So I think you've got the virus and no 5G. That already sort of defeats that one, right?
Yeah, slightly. So getting to the vaccines now, obviously great news. They're out. We're getting them distributed. It looks like we're getting even more purchased now that are going to be here in the summer. And so a much more concerted effort to get people vaccinated. Luis, what are you hearing, or what are some of the things that people need to consider, or some of the concerns they're expressing that may, in fact, not be true?
Yeah, I think right now we're kind of at a interesting time in the vaccination process, or vaccinating the whole U.S. kind of process, in that we hear, about vaccine hesitancy. Some people have concerns of getting it, yet if you look at, there's huge lines, there's stories about people that probably need to get it, that can't get it. So we're right now in this kind of point that's kind of very, very challenging to really start pushing people to say, we want everybody or need everybody to get vaccinated, to really have the maximum input of immunization, which, just looking at immunization as a public health kind of intervention, which it is, we can go way back in history and time to see how immunization is a public health intervention. So this is going to be a dialogue that'll be going on to really talk through these myths, various ones that might be reasons for vaccine hesitancy, and start to paint a picture of why you want to get it, why you want to get the vaccine. And so that's what I think we did this. We thought it was a good opportunity to kind of surface some of those reasons why people may be hesitant to get the vaccine.
So let me bring up one for you, Luis, that we discussed beforehand. This idea that there are all these deaths after the vaccine, and people are dying from getting the vaccine. What are we seeing from the vaccine in terms of deaths?
Yeah, I'm going to relate this to kind of this goes back to deaths from COVID. I'm going to relate it back to that and how we can look at kind of baseline of events. I think one way to look at it is, so one way we know how many people have died of COVID is this excess deaths. Looking at these year over year trends, with statistically, we can kind of really very accurately predict how many people are going to die of certain things even and such. And that's this excess in deaths kind of really connected us to saying, these people died as a result of COVID in the system. But to put that into context with the vaccine and events is certain number of events are going to happen regardless. Every single day, somebody will get hit by a car. Somebody will get diagnosed with cancer. Somebody will, a 95-year-old will pass away. And so I think we have to look at when an event happens, and just because the vaccine was proximate isn't a cause and effect type of thing that we have to look at. That's why it's important to look at populations and look at big data sets to really draw conclusions about these things. And really based on those conclusions, we had a lot from up to the phase 3 studies and things like that. There's really no reason to be concerned about these adverse outcomes or this leading to some severe adverse outcome as a result of the vaccination.
Right, and as you mentioned, that phase 3 trials were like 30,000 people or 40,000. So if you're running that over a number of months, you're going to naturally see some deaths occur in that population from various clinical conditions or elderly or whatever. And so, they're not necessarily related to the vaccine itself. So a really important point. What about, Nick, this issue of these mRNA vaccines use nanotechnology and they're going to track me or something? What are they doing with the nanotechnology in the vaccine versus what you would consider a tracking bot or something like that?
Yeah, so I always try and think where these ideas come from. So, the association of nanotechnology, obviously if others are like me, they watch television. We've seen some fantastic concepts in various science fiction series with nanobots. And, I think we're going to see nanobots in my lifetime that will be used for delivery mechanisms. But right now, we don't have anything that is injectable that could survive that process. We do use nano. What does nano mean? Small. It's small technology for the construction. And in this case, it's the construction of the vaccine that is created from a genome sequencing, but then bundled up into a molecule that is a carrier specifically to allow it to be injected into the body. In fact, RNA vaccines have been around for a while, but they've been, I don't want to say useless, but they were ineffective because when you put them into the body says, oh, this is some materials that I can use and process and consume, and they get consumed and they do nothing. So we had to put it in this very clever lipid molecule that allowed it to be protected. And that's part of the reason for the cold storage. So I think there's a little bit of confusion around this term nano that says, gosh, we're injecting a chip. And then, later on, there are some hackers out there, biohackers, who have injected chips into their body, a bit like we inject chips into our cats and dogs for tracking. They've done the same thing. So that is possible. There's some, it tends to be at the edge. But in terms of what's going on in this vaccine, yes, we use nanotechnology to create it, but there is no chip or robot or anything that gets injected in. It's part of the construct of this particular vaccine, I'm sorry.
And I think on a related topic in that area, there's also this thing that says, well, I'm going to get this mRNA vaccine and it's going to change my DNA. But do you want to address that one, Luis, and where it really goes and how it works?
Yeah, we got to remember that a virus in and of itself is essentially a genetic, is an injection of genetic material. So really the messenger RNA piece as Nick kind of described, this has been out there for a while, is just one segment of that genetic code or genetic makeup of a virus. And we're taking one little piece or snippet of that and using that as a delivery system and a way to kind of trick or the body or trick the immune system into saying there's a threat here. That's what we're trying to, that's the goal of this, is we're trying to let the body we're trying to trick the body into using its immune system for that. So, but in terms of our body, our own DNA does not change as a result of seeing genetic material come in. I mean, again, we get that all the time, and there isn't a change to that. Now, I mean, you talk about epigenetics, and the environment does alter, things, and even in looking at these viruses, you talk about mutations, and mutations happen and things like that, but they're not as a result of our exposure to genetic material such as the mRNA thing. So really, there's absolutely no reason for concern there. We've been doing, as Nick said, the messenger RNA technology has been there for a long time. We use other genetic material. Really, you were using the adenovirus to deliver the Johnson & Johnson system. So there's different kind of delivery mechanisms to do this, and none of those impact our genome.
Mm-hmm. Anything you'd like to add to that, Nick? Or?
No, I think that's exactly right. It's building. I always like to use my Lego analogy, because I think people can associate with this. And sorry, I picked Star Wars again and the Death Star. I don't know that that's the right thing, but the virus molecule is the Death Star. I think that's a good visual. Quite frankly, it feels that way, certainly after 2020. What we're doing with these vaccines is taking pieces of it and saying, here, this is a piece of the virus to our bodies, and you can identify this part of the Death Star when it shows up as a complete Death Star, and then you're equipped, you're ready to recognize it and shoot it down. That's essentially the basis of this technology, but it's not changing anything inside. It's essentially creating this reactionary force that can prevent the infection that's caused by the SARS-CoV-2 virus.
Right, and in the case of the mRNA vaccines, it's getting it to recognize portions of the spike, and in the other vaccines, I understand it, that will be made from an attenuated virus or something. They'll make it out of that, like the older vaccines were done. Is that correct?
Yeah, so each of the vaccine platforms comes with a different set of strategies as to how it looks. And, you look for the various elements that are in there. And we're essentially trying to create an immune response as a result of that. The four pieces that I'm aware of, the protein spike, the protein membrane, the protein envelope, and the nucleocapsid protein, are all targets that you can use different vaccine strategies. And as you rightly pointed out, we have this virus-like particles. We've got messenger RNA that codes for that. We have inactivated viruses. We have got live attenuated. They're all sort of various strategies. I forget what the total number was that I saw, but the messenger RNA is just this wonderful platform that is much more agile in terms of creating new vaccines quickly, which is good news. And as of today, there are 11 vaccines that have been approved in at least one country.
Wow. And so what's the issue now, or belief, of those who have already been infected and then getting the vaccine? Where are we with that?
Yeah, well, I guess I'll jump in first on this. Well, certainly we know that folks that have had an infection have good immunity to COVID. So reinfection is very, very, very low, very low rate of reinfection. So really, those people have already had that native immunity from having the disease, and as such have protection. Now, the vaccine is going to give a more predictable, the idea is giving a more predictable response the immune response to it, and is going to be more studied and measured in kind of that under the lab circumstances, so you can say how long it's going to last and things like that. But honestly, there was I think an opinion in the Washington Post. I think it was Dr. Macri, I think, posted. He thought that people that have had an infection should have probably been asked to kind of go towards the back of the line as far as the line. But just because they have, if our goal is to reduce new and severe infections, the way to do that is doing the most vulnerable. And there, the argument I think would be that group is probably not the most vulnerable as far as that goes. But I think universally, it's felt that they should have the vaccine. To ensure that they have that more predictable immune response and protection.
Mm-hmm. So it's something that, at this point, I guess we're vaccinating those individuals and saying get it because the science shows this, and we just don't know whether they've achieved a high enough level of immunity response from their infection. Right. But at some point, it may be looked at differently. But for now, this is sort of how they're going. Interesting. And what about the issue of, and I'm a little worried about this one. Once I've had the vaccine, I can go back to 100% normal. Where are we with that?
Well, to be clear, at some point we're going to go back to something. I don't know that we necessarily are going to define it as normal, because it will be the new normal. There's going to be a difference to our world. Again, I like to use analogies, and I happened to travel to Japan shortly before this pandemic outbreak. And one of the things that was notable to me that stood out as a Westerner in that society was traveling around in Tokyo and seeing people wearing masks. Not everybody, but some. And I think what we're going to see is more instances of that in our society, because they've been exposed to a series of infections, and they've been sensitized to this. And mostly in those instances, the masks are worn by people that think they might have. In this case, it could have been just simple colds, flu, and so forth. And they don't want to spread it, so they actually try and protect others. We wear masks for a different reason, to be clear. But the point I want to get to is, for us to return to whatever this new normal is, where life is back to something approaching social interactions that we've had before and dinner out and so forth, requires the virus to essentially no longer, it can be a no-demic, as I like to call it. It will probably be still around, but it can't be constantly replicating and expanding. And until we reach that point, we're not going to be able to change or reduce the measures. So we must enact all of that, even whilst we're vaccinating the whole population. And by the way, this is not just the United States or the United Kingdom or any other country. This is the world because of international travel. So this permeates throughout. So we can't just say, whoa, we've got the whole of the US vaccinated, right? All bets are off, because of course that's not true for the rest of the world. So we have to get to this level of herd immunity. We're not quite sure where that is. And once we've done that, we then have to apply appropriate measures to say, how are we going to protect ourselves? Because guess what? There's going to be other versions of viruses that will impact us. We've seen a whole series because we've got SARS-CoV-1, MERS, and others. We have to be better prepared. And hopefully, as a result of SARS-CoV-2, the world in general, not just the Middle East and the Far East that I think were better prepared because they'd had previous experiences, are all going to say, we're going to take this seriously and we'll be much better in the way that we respond, so that we don't end up with a worldwide pandemic.
Mm-hmm.
Yeah, I'll kind of add into what Nick said, a couple things. One, in the initial studies of the vaccines, the existing vaccines, they didn't, especially I'll just say the Pfizer vaccine, they didn't test whether you could pass on the disease if you got the vaccine. That is, if you're exposed, could you still be a vector for passing on? So they didn't have that. They have a pretty good idea, and the Moderna did do some sampling and things like that. So I think there's pretty high confidence of that. But we also do know that we hear about 95% efficacy, but there still were cases in the trials of people getting COVID. So again, it's not predictable. So we're at a point in the pandemic, as Nick said, where we still have very high numbers. We all need to be wearing masks, period. It's part of that Swiss cheese approach. We need to be taking every single precaution that we have. I think I saw somebody get criticized when a doctor, or actually I think an infectious disease doctor, said, I missed that time when, now my nurse is vaccinated and I'm vaccinated, where maybe we could at some point have a hug or something, that type of thing and stuff. And she kind of got kind of crucified for that, because she's saying that as they were both vaccinated. But I think the idea is there's going to be time for that. Our scientists will communicate to us. CDC, I think, will communicate to us when we can start kind of loosening these up as numbers go down. We have good data from Israel that we've seen that as larger numbers get vaccinated, we are seeing the curve go down. And so I think those type of things are promising on that. But for now, we have to say that we all need to continue, even once you're fully vaccinated, you need to continue to take the same precautions for all of us.
Yeah, I think that's really a great point, because you'll have situations now where one person in the house is vaccinated potentially and one person is not. And whether you're the vaccinated or the not vaccinated person, you need to continue, wear the mask, wash the hands, keep the distance until we get to that point, like you said, where the science demonstrates that we're comfortable doing something that may be different than that. Are there...
I want to hit off one other myth that I think is important for people to understand, that I've seen trending a little bit, is you can buy in to getting early access to the vaccine. There is a bunch of people that are trying to sell access to the vaccine. And I would caution people, A, you have no idea what you're getting. B, it's completely inappropriate. And C, this is almost certainly a scam of some description. And please don't get sucked in. There are, open, honest processes. There's certainly been some mistakes and, instances we can point to and say, gosh, that wasn't quite right. But I think everywhere is good intention. You will get access. You are not paying for this, and there is no early access. I think it's important for everybody to understand. We will get to it. You will be gotten to, but you're not going to have to pay for early access or even access at all.
Good point.
What about the issue that I've heard come up a couple times about, hey, I may be allergic, so I'm just not going to do it?
If you don't mind, I'm going to pick off this, because this actually came from a family member. My brother's a physician, and he's volunteered back. He went through the 21 training courses that he was required to go through, including sensitivity training, fire training, and so forth, that's required in the United Kingdom for a GP of 30 years to be able to give vaccines. But he was also offered access. And he tells me a story. I hadn't realized this. He has a severe allergy to wasps that came from an experience in the Amazon. So he actually elected to wait for the AstraZeneca vaccine rather than going with the RNA vaccines that were available. And I think people have to make their own selection based on, well, not the individual, but they should, in counsel with their clinician, make the appropriate selection. And there are certainly going to be people that maybe are ineligible to have a vaccination, which is why the duty is on all of us that are able to take vaccines, need to have them. It was kind of a learning experience to discover that he was so allergic to wasps, especially when he visited me, and I didn't know that. And I have a big wasp nest that I have to deal with on a regular basis.
Those are some tough allergies.
Yeah, I'll just add to that, because Nick kind of mentioned it. There may be some people that can't get it because they've had an allergic reaction to a vaccine in the past. And I think now the current one, there was kind of some question is they're not right now recommended, don't get it now if that's the case. but there's a lot more people that's a very, very, very small number of people that have had those kind of reactions. There's a lot like Nick's brother, peanuts, other allergies and things. And usually most of those people may even carry EpiPens and things like that to be prepared with. And that's why people with a reaction, history of an allergy to something, if you have a history of an allergy, you're going to watch you for 30 minutes. Whereas if you have no allergies, if you have no history of allergies, they're going to watch you for 15 minutes. And they all of the reactions, which the number has been extraordinarily low of allergic reactions to both the Pfizer and the Moderna vaccine, but they generally happen within that period of time, and those can be easily, in most cases, can be easily managed. I won't say every time, but most cases, if they're caught early and treated early and under good medical observation, can be treated rapidly. Much like that's why people carry EpiPens, and because they can treat those responses properly as well.
Great. We had a good question come in too. Once you get the vaccine, how long before it works to protect you? What are we seeing in that sort of data?
Well, I'll start on that. So based on, and some of the, I think most of the data, I think that I've seen, the good data on this, I think it applies to both the Pfizer and the Moderna, but I came from the Moderna study. And if you go and look for their the data that they submitted to the FDA, you see this graph that shows kind of the protection, and you start seeing it even after the first dose. After 2 weeks after the first dose, you start seeing it more after about 30 days after the first dose, which is about the time of the second dose. Big reason for that is that first 2 weeks, I don't think you can draw any conclusions. You could have been exposed before that, so it's hard to draw any conclusions. But they talk about 80% possibly protection even after a full 2 weeks with the Moderna. But then you get to the higher numbers after the second dose. When 2 weeks after the second dose, I think that's kind of when everybody would feel after 2 weeks after the second dose that you have the maximum protection. And that's what I would recommend to people, that if you're thinking about that, that's the time to think that you probably have the maximum protection based on what we've seen. And I don't know if Nick has anything else to add on that.
No, I would just say that's exactly what I would have said. The only addition I've got to that is, even when you've got maximum protection, keep wearing your masks and doing all the other things. Right.
So if individuals have, additional questions, obviously, we'd be happy to answer those, or you can submit them to us. Next week, we'll be doing another session. But also, I think it's important, if for people who have questions, really look to the communication sources that are valid. Look to the CDC, FDA, talk to your physician, and get the answer that's right for you in terms of this. But I really appreciate you guys going through all the data and discussing the various myths. I know there are a bunch more out there we can get to. So thanks a lot again this week for joining us, Luis and Nick. As always, it's a pleasure.
Thank you.
And with that, we'll end this session. Thank you so much for joining us. We'll have the list for the topic for next week up probably tomorrow. And we thank you for joining us. And please feel free to, as we said, submit any questions you'd like, or you could ask us things later. Thank you.